Thanks, David, and thank you to the organisers for the invitation to come and speak at this Festschrift in honour of Hatem's wonderful career. And thank you, Hatem, personally for persuading me about 5 years ago to cross the Yarra to try and take on this very difficult disease. So today I'm going to give you some idea of the progress and challenges facing the AML field, a condition which was morphologically described as an entity over 160 years ago. In fact, the first controversy in the field was who actually identified it. We have John Hughes Bennett from Edinburgh, a great pathologist who described the term leukocythemia, followed 6 weeks later by Rudolf Virchow from Berlin, who described a patient with a high white blood cell count, and he coined the term white blood or leukemia. However, it was in fact a little-known Frenchman, Alfred Francois Donnet, who 1 year earlier, with his great fascination for new technology and particularly clinical microscopy, who gives us the first image of leukemia. And in his words, he described several cases which existed with a great excess of white blood cells, and he speculated that the excess of white blood cells was due to an arrest of maturation of blood. And I think this is a very prophetic statement for his time and is a reflection of one of the hallmarks of acute leukemia, which is arrested differentiation. And so here lies one of the great paradoxes of AML. We have a disease where we know more about this condition than almost any other malignancy, and yet the last therapeutic advance for this condition arose more than 50 years ago. We knew as early as the 1930s that leukemia could be transmitted to mice with a single cell, and work done by John Dick's lab in Toronto suggested that a very small fraction of leukemic progenitors could recapitulate the disease, thus supporting a hierarchical model for AML, and perhaps making less likely the stochastic model, which predicted that each leukemic fraction would have this potential. In the 1990s, cytogenetics gave us a really important avenue towards personalised therapy. Cytogenetic abnormalities through clinical observation could be categorised into 3 prognostic risk groups, and using this we could now identify high-risk players who should receive an allogeneic stem cell transplant. At the completion of the Human Genome Project in 2003, the first cancer genome was fully sequenced in 2008 by a team from the University of Washington. And for the first time, we could now identify all of the complements of genetic lesions in a single individual with a cancer. However, when we think about the therapeutic discoveries in this area, we have to go way back to 1955. Werner Bergman and Robert Feeney, who were organic chemists working off the coastal waters of Florida, identified this unusual, previously unidentified sponge called Cryptotethia crypta. When they boiled this sponge and extracted the solid substances, they put it under ultraviolet analysis and realised that it contained a thymidine structure and also a sugar ring. And this very much reminded them of the basic building blocks of DNA and RNA. They named this substance spongothymidine, and when they analysed its effect on organisms, they found that it inhibited DNA and RNA replication. And this ultimately led to the synthesis of Ara-C by Seymour Cohen, and our very first effective drug for this condition. In 1963, there were 2 groups working on soil bacteria. Soil organisms in the dirt essentially represent the digestive system of the soil, and an Italian group identified a substance called La Dornamycina. And simultaneously, there was a French group led by Dubost who was extracting organisms, another type of organism, and they found a substance called La Rubidamycin. And it only occurred to them later that this was in fact the one and the same type of substance. And after presumably a handshake agreement, they merged the 2 terms, and we now have dornirubicin. Dornamycina came from the term Dorni, which represents a tribe which migrated into Italy during the Bronze Age, and rubidamycin reflects the ruby-coloured substance which was originally extracted. And so, up until the 1960s, very few patients with AML actually achieved complete remission. This was a diagnosis which portended doom, and there were no effective therapies at that time. So with the introduction of daunorubicin and Ara-C, we now have 2 active agents in AML that could produce complete remissions in about 25% of patients. And this spurned a flurry of clinical trial investigation to try and combine these organisms and optimise the dose to try and improve on the clinical outcomes. And in fact, probably the most important trial ever conducted in acute myeloid leukemia occurred in 1973, where Yates and Wallace did a very small study, only 16 patients, but they used this now very famous 7+3 regimen, 7-day infusion of cytarabine and a 3-day injection of daunorubicin. And they achieved complete remissions in 60% of patients with untreated AML and about 25% of patients with relapsed AML. And it's absolutely remarkable how contemporary these figures still remain in 2013. If we had to write a fairy tale script of how we would try and cure leukemia, we really can't go past acute promyelocytic leukemia. This condition was first described in 1957 and originally described as the most lethal of all blood cancers, a condition which, when we gave chemotherapy, patients frequently died from disseminated intravascular coagulation and unabated hemorrhage. In the 1970s, daunorubicin was able to produce long-term survival outcomes in about 1/3 of patients. However, it was in 1985 when a group from Shanghai treated a 5-year-old girl who was essentially given up for dead by her parents after failing 2 cycles of chemotherapy, and was persuaded by Huang to take a vitamin A derivative called all-trans retinoic acid. An update from Huang a few years ago reports that this young 5-year-old girl lived for the next 26 years and had a very productive and successful career. 7 years after the introduction of ATRA, another Shanghai group discovered arsenic, which also had very active activity in acute promyelocytic leukemia. And these 2 drugs in combination function not to kill the leukemic cells, but to remove the differentiation block and to allow these promyelocytes to differentiate into harmless neutrophils. And in Australia, there have been 2 national studies, one combining ATRA with chemotherapy, the APML3 study, and more recently, a further study which added arsenic to this equation. And you can see now that with a relapse-free survival of 98%, cure is in fact the norm for this condition rather than a bloody death. And so what other relevant and disease-specific targets can we hope to try and recapitulate the success with acute promyelocytic leukemia? The problem here is the fundamental complexity of a disease, where you can see there are so many different types of mutations, and many of which comprise only a small fraction of an already fairly rare condition. And the clinical trial structures in this country were essentially all comers with acute myeloid leukemia given either increased doses of existing agents or trials of new agents. And you can see here 4 randomised studies performed over 25 years involving almost 1,200 patients has resulted in 3-year disease-free survival rates of about 54%. So of the adult population with AML, about half can be cured with conventional therapy. And we have no further room to escalate the doses of chemotherapy, and so we really must identify novel therapies. However, the likely dissection of acute myeloid leukemia into not from one disease into potentially multiple cytogenetic and molecular entities required us to completely change the way we did business in the clinical trial arena. And so we had to introduce what's called a modular approach to clinical trials, whereby we basically treat different subpopulations of AML with a more tailored regimen. And more recently, we've introduced a randomised trial for FLT3 positive AML, which is a very poor risk outcome, often affecting younger patients, and introducing maintenance trials to try and reduce the risk of relapse from AML. However, the problem we faced in a practical sense was how do we possibly approach a patient at the time of diagnosis, having a bone marrow biopsy, with potentially 4 or 5 clinical trial protocols before we even knew which entity we were dealing with. And so this heralded the notion of establishing a national leukemia registry framework whereby all patients that present with AML were presented with a common registration platform, and once a diagnosis was known, then they could be entered into a trial specific for their disease. Some other benefits which we hope to achieve with the National Registry include linkage of clinical and genetic information to treatment outcomes, developing a repository of diagnostic and relapse samples so we can try and understand the mechanisms for treatment failure. And I think more importantly, in the current climate of health economic constraint, analysis of quality of life and cost effectiveness of our treatment regimens to really validate what we're doing in day-to-day practice. And so this registry is currently being opened in centres all around the country. And as I mentioned, I think we will be under more pressure to consider these health economic considerations when we conduct future clinical trials in a fairly rare disease like AML. AML comprises only 1% of all cancers, and yet it consumes 6% of the cancer health budget. The Australian healthcare expenditure is already in excess of $150 billion per year, and the cost of subsidising new cancer drugs has increased from $65 million to over $500 million in the last decade. And when we look at the PBAC, they really do have a yardstick of a new treatment having a quality of life adjustment benefit of less than $50,000. So there is a plethora of new drugs currently being developed, and on last count there are 1,400 clinical trials in AML currently active. So how do we actually select a candidate for clinical development? Two problems which we face are, as I've mentioned, the molecular complexity of AML. How do you target a target when there are so many targets and so many targets in combination? And also, we need to recognise that acute myeloid leukemia is an inherently unstable cancer. You can see here a number of cancers next generation sequenced, and in red are the additional mutations which emerge upon clinical relapse. So we're looking at a moving target, not just a complex target. So Ben Kyle has already talked about pro-survival mechanisms sustaining cells, and most multicellular organisms have a programmed mechanism for dying called apoptosis. And apoptosis was the first protein identified in this pathway was BCL2, and this was work famously done by David Vo from the Walter and Eliza Hall Institute. These BCL2 pro-survival proteins keep cells alive by preventing apoptosis, and they are neutralised by a family of pro-apoptotic molecules called BH3-only proteins. And so our question was, can we destroy the survival of leukemic cells by abrogating some of these pathways? And as Ben has already mentioned, we now almost have a therapeutic toolbox for doing this with the emergence of drugs such as ABT737, which acts like a bad mimetic targeting BCL2, BCLX and BCLW. Recently this year, a drug specifically targeting BCL2 has emerged, ABT199, and it's likely that later this year there'll be a small molecule that will specifically target human MCL1. The problem with acute myeloid leukemia, however, is that we already have patients who have a compromised hematopoietic system, and thrombocytopenia already places our patients at immediate risk of bleeding. And so really we would like to avoid, if we can, any agent which targets BCLX for all the reasons which Ben's already discussed. So we decided to use a construct from Stefan Glaser, who now runs a laboratory at Walter and Eliza Hall Institute. He's produced a very nifty construct which can enable us to inducibly express BH3-only proteins to target either all of the pro-survival molecules using a BIM wild-type form, a select group of molecules similar to the drug ABT263 in the form of BIM bad, and a construct which can selectively target MCL1, which would perhaps recapitulate what we would expect with a small molecule doing the same process. This construct, you can see, has very little leakage. We're not given doxycycline, and when the construct is placed into leukemic cells and transjected into mice, We can then switch on the doxycycline and the transgene at day 5 and look for the effect on trying to target leukemia in vivo. We were quite surprised in the fact that when we targeted only a subset of these pro-survival molecules, we did get a partial response, but not a cure. So you can see here that targeting MCL1 with BIM2A gives some sort of benefit, but really not a cure. And the same thing when we only targeted BCL2, BCLX and BCLW. It's only when all the pro-survival molecules were targeted with the BIM wild-type form that we're now trying to see the types of responses that we really want to see in humans. And so history tells us that AML is rarely cured by one drug. We have 7 and 3, and we have a combination of ATRA plus arsenic or chemotherapy to give us examples of how we might cure patients without an allogeneic transplant. And so the strategy for us is to find a drug that is active in primary AML and which perhaps complements the activity of these BH3 mimetics which are likely to emerge. And so one collaboration which we've established with a chemical biology division at the Hall Institute is to look at the sorts of molecules which are either in late phase development or already registered for other cancers. And this is work done by David Segal, where he's taken a whole bunch of leukemic cell lines, tested them against a range of what we consider to be high asset drugs. And you can see the red indicates cells which are very sensitive to these drugs, and in green, drugs which are relatively resistant. From a translational point of view, what we would like to do now is to see how does this compare to primary human cells. And you can see here that this is a human primary sample which we provided to this group, and you can see here that the spectrum of activity is quite different when we compare it to another cell line which actually has the same mutation. And so from our point of view, I think we have much more traction if we take a molecule which is active against a primary human leukemia, especially if we can reproduce the same results by expanding this set out to include more patients. And so there are drugs which we would obviously be interested in testing, but obviously drugs which we wouldn't necessarily test in primary AML settings. And there may be drugs which are active in primary AML cells which we wouldn't have considered if we had looked at the cell line alone. And so in closing, I'd just like to say that it's been 160 years since leukemia was first described, 40 years since the introduction of 7 and 3 chemotherapy, which is still our frontline therapy in many centres. It's been 5 years since the first complete AML genome was unlocked, and I believe that the tools to actually cure AML may already exist today in our pharmacopedia. And our challenge over the next 10 years, 5 to 10 years, is to try and identify the right combination of drugs that will hopefully enable us to supersede 7+3. Thank you.